on, so, oh. Yes, with IgA nephropathy, right? Everything else is primarily smoking. I heard it first. That is absolutely correct. That's our prototypical patient, old smoker, painless, gross vegetarian. That's it. And then another easy one. Yeah. Painless testicular mass. That's how it's usually going to walk in, right? And then what do? Get an ultrasound. That's right. Okay, good. Any questions about that? I mean, that was a pretty easy day, I think. And today, I think you will find that today's material is not that hard either. All right, anyway. So, any questions up to now? Easy stuff. We're going to do erectile dysfunction and we're going to do infertility. They sort of go together a little bit. And then we'll finish up tomorrow with incontinence, which should be pretty quickly gotten through. And then we'll do a review. What have you guys decided? We can do a review tomorrow. We can do a review later. We'll see. We'll figure it out tomorrow. All right. Either way, it'll be done. So disorders of ejaculation. Erectile dysfunction is sort of a global term, sexual dysfunction, if you will. Disorders of ejaculation go in with it. We don't cover them specifically other than this slide to talk about them because they are issues that your patients will come to see you about. Okay, so we have to understand them as well. And ejaculation or retrograde ejaculation, two potential sources of infertility, caveating into the next slide deck. Retrograde ejaculation is potentially something that you will see in a diabetic patient, is most common. Subset of patients that would be involved in. And then premature ejaculation, again, that is a sexual dysfunction in the global term that your patients might come in and complain of. The definition of that is ejaculation, achieving orgasm before the desire to, essentially, literally. And does anybody know what can be used for that patient? What type of medication? Huh? SSRIs, yes. And then they have other, other things to delay ejaculation. But in our milieu, like primary care, you can utilize some of our SSRIs, which one of the sequelae, one of the side effects is delayed orgasm, delayed ejaculation. So in that case, we're using it to our benefit. All right. The erectile anatomy, we have discussed it when we talked about the penile fracture. The tunica albuginea that covers and surrounds both of the cavernous bodies, the pericavernous bodies, allows it to engorge and maintain a rigidity of an erection through an obstruction in venous outflow. All right. Physiology of erection, don't have to go, that's it. We don't have to go too far into it. Really, what we need to is talk about is the PDE5, which is going to be our main source of pharmacological in treatment for erectile dysfunction, PDE5 inhibitors that you've probably talked about before, I imagine. We talked about the term tumescence, right? So tumescence is an achievement of an erection, the rigidity of the erection. Detumescence is returning back to a flaccid state. And if that doesn't occur within 4 hours, what do we call it? Priapism. Right. Okay. So physiology of erection. Nitric oxide. Now I bring nitric oxide up because it's marketed as a ED treatment, over-the-counter supplement type treatment for, it is a potent vasodilator, but it hasn't been shown to directly contribute to erectile dysfunction treatment. Okay, so the reason I bring it up is because patients will have tried a lot of this stuff, and nowadays, to be honest with you, if you guys have heard of HAMs, you guys have heard of Blue Chew, stuff like that. People can get direct-to-consumer Viagra treatments and other supplements, so it's imperative that you ask them if they have tried any of these things, because the last thing that you want to do is prescribe them something on top of something else they may already be trying, right? Because then you can bottom out their blood pressure and have some serious side effects. If they're taking a Blue Chew or something they get from 4Hims and then you give them Viagra, they double up not knowing that they're the same thing. So just make sure that you understand that patients can get a lot of this stuff direct to consumer nowadays, which is not I mean, it's good in the fact that patients have access to it. Some patients are really, really uncomfortable, really embarrassed to go sit in front of somebody and talk to them about this. So the fact that they can do this through telehealth is good. However, some of the, it's fairly spurious how easy it is to get some of this stuff through a site like Blue Chew or Forhims or other places like that. It's, not necessarily quite as rigorous of a medical history of a patient, family history, so on and so forth, that can really uncover any potential problems that the patient might experience taking the drug, okay? So just make sure you ask about stuff like that, including nitric oxide supplementation. But really, all those previous slides, the reason I kind of went through them quickly is because what it boils down to is what we need to inhibit is this right here, right? So PDE5, this cycle, is normal erectile physiology, right? When there's an overwhelming amount of PDE5, you see how it takes a turn and inactivates. So cyclic GMP basically leads to that detumescence, or the inability to attain or maintain the erection, right? So that's why that PDE5 is the site of where all of our Viagras, our Cialises, our Levitras work, okay? And they do work fairly well. So, two different things. Again, I mentioned just now, when you are taking a patient history and somebody's complaining to you of erectile dysfunction, you need to ask them if it's a problem attaining an erection, maintaining an erection, or if it's a problem of both, okay? It is extraordinarily common, right? And it's not a problem just of older men, So just understand, I guess, the first thing I let off with was a stupid tongue-in-cheek joke. And the jokes do write themselves, but just do remember, when you're seeing your patients, and it might be somebody that you, again, see every single day, it's somebody in your unit, just maintain a balance. That's not the time to test out your jokes, you know what I mean? That's not the time to test out new material. Because if they might not find it funny, and then you're gonna lose their trust, and then they're not gonna come see you, and then really what service are you offering them? So just, in here, we can joke around a little bit, but in the patient room, it's not really the best time to trial material. All right. Organic versus psychogenic etiology, and there is a seemingly silly but very easy way to determine what that might be primarily. I will tell you that in almost all cases, it is going to be a little bit of both, okay? It's what happens what I call like a vicious cycle. First time a man experiences erectile dysfunction, it kind of sticks in the head, right? It kind of gets in your head. And then the next time they go to have sex, the anxiety of the previous event leads to increased anxiety, and then that works against itself, and against itself, right? Because, again, this is a parasympathetic response. If the patient is too much in a fight or flight, it's like sympathetic stimulation, then the whole cycle, that normal physiology isn't going to occur. So this is something that can really build upon itself. Even if it is initially an organic, physiological problem to begin with, the psychological component can end up being what makes it tremendously worse, okay? So, truthfully, ask your patient if they ever wake up with an erection, right? Do you have erections at night? Most of the normal erectile physiology, patients wake up, you guys have heard of morning wood, right? Literally. If that occurs, if your patient can recount to you that they do have erections in the morning, or they do wake up at night with erections, then that tells you what? Then it works. That, primarily, the physiology works. So it leads us more to a psychogenic or anxiety type definition or etiology, if you will, all right? Not everybody's going to know this, but they actually do, as you go down the pathway of investigating erectile dysfunction, and not everybody is lucky enough to be successful with oral medications. And these patients, as they're going to try to regain their normal sex life, if you will, there is actually a nocturnal tumescence monitor. Looks like a little holster with little electrodes that go around the penis and monitors for nocturnal tumescence, right? It's like a sleep study for this, if you will. And there's a picture of it later on. But think about it. Here's the thing, and I've said this before. When you get to something like erectile dysfunction, you lose the ability to have sex, right? Or you take something that is supposed to be an enjoyable thing, sexual intercourse with your partner, loved one, or whoever, and now it becomes this anxiety-ridden thing, right? So we're talking about relationship problems, we're talking about personal embarrassment, we're talking about just the inability to perform that act. It is a huge quality of life issue for your patients, all right? So they will go to as long of a length as possible, up to and including surgery, to get that back. So don't discount that, and there are steps that we can take after medicine. I'll tell you this, bottom line up front, for our purposes in here, if they fail oral medications, they just need to go to urology, all right? And we'll get to that in a minute. But generalized versus situational type, as far as two different etiologies of psychogenic, digressing back to the cause, the root cause of the erectile dysfunction. Again, generalized doesn't necessarily mean involving another person. This person sometimes cannot even achieve an erection in order to masturbate, or they lose the global sexual inhibition where they don't even have any kind of libido anymore. So that is another thing to ask. Not just are you having issues with erection when you talk to your patients and you ask about their history, like do you have the urge to have sex? Do you have an interest in having sex? Or do you have an interest in masturbation? You have to ask these questions to your patients to know where they are along the spectrum, all right? Organic nocturnal erection, no. A little bit more difficult to say 100% no. The patient just might not remember, it might not, occur to them to think about it. So, truly a true organic etiology is, it's not rare, because what do you think, honestly, what do you think one of the most common etiologies of organic erectile dysfunction is? Huh? Medication induced, okay, yeah. But what else? Hypertension, atherosclerosis, I'm hearing a lot. Cardiovascular risk factors, that's what it is a lot of the time, right? And urology recommends that at ED be an entree into potentially talking to your patient about their cardiovascular, cardiometabolic profile, because it sometimes is the first manifestation of that disease. Atherosclerosis is really what we're talking about. Of course, smoking and all that other, but you'll see when we get to like the overlap of the risk factors, they're the same for cardiovascular disease, okay? And then this is what I was talking about. Regardless of the ultimate etiology, it really does, the psychogenic portion typically does sort of play the role of worse. I don't know the word I'm looking for, but it usually takes over as the main cause of the etiology, right? You know what I mean? When you get that vicious cycle. Let's say it is an atherosclerotic patient, and they do have literal plaque buildup, so they don't have as much blood flow. But then the psychogenic part really starts to take over after that. So looking at this right here, this is what I was talking about. Vascular being the most common, and that risk, all those risk factors, I'll just switch to the next slide. You don't have to memorize all of this, it's pretty obvious, but older, yes, risk factors go up, but again, not just a problem of older men. Diabetes, on every list, right? Dyslipidemia, hypertension, smoking, so on and so forth. Obesity, sedentary lifestyle, right? Sounds pretty common. So, when we're taking a history, again, what's the problem? Getting an erection, achieving an erection, maintaining an erection, or both, okay? Does it happen in all situations? Are you able to? Like if you're by yourself and are you able to masturbate and achieve an erection? That's the question you ask. Is the problem only when you're with your partner or with another person? Okay? Obviously, do you have any other sexual dysfunctions that are going as comorbidities? Loss of libido, inhibition, so on and so forth. So what else is going on around it? And then risk factors, clearly. And again, like I said, it's usually a good way to start talking about cardiovascular risk factors. And it might not be there. They might not be there. But it's a good way, it's a good reason to ask. Because patients, a lot of times the initial presentation of cardiovascular disease will be something like erectile dysfunction. Because again, until you have your heart attack, does atherosclerosis really manifest any obvious symptoms? Does hypertension really manifest any obvious symptoms? Exactly, right? So the patient can have had these things for a while until they progress to the point now where they're manifesting where a really obvious symptom that the patient then wants to go in for. Okay? And you guys mentioned in the back, some antihypertensives, of course, the antidepressants that we use for the premature ejaculation can cause now problems. More often than not, SSRIs, obviously MAOIs and TCAs, we're not using a whole lot except in the chronic pain sort of area. But SSRIs, the problem that the patient will experience typically will be maintaining an erection, not necessarily attaining an erection. All right? And then antihistamines and diuretics possible. Okay? Obviously there's others, but these are just some of the more common culprits. Okay. Questions so far? Another standardized form, again, just like the AUA score, it gives your patient the ability to sort of standardize how the treatment is affecting their quality of life. All right? And again, I don't know why people think I make this shit up. SHIM is the real name for it, is the shortened score. The IIEF 6 is the longer version, all right? So you can take these, and either one really gives you a decent picture of how this is affecting your patient. But again, what it really does is it allows you to know at baseline, where are they? At treatment follow-up, are they getting better or worse? And then it communicates on to your consultants exactly the number. This means the same thing person to person to person. So they can understand that, all right, we're getting better or we're getting worse. Okay? And again, this is the shortened version. The longer version is 15 questions. And it's really just the same. It's a Likert scale, and they're just circling the numbers, and you add up the numbers for their total. And it really does help, again, objectify that data. Physical exam, looking for any kind of signs of androgen insufficiency that may be leading to this. But ultimately, unless there's something like that, there really isn't going to be much on the physical examination. Genital exam is warranted here because you want to check for testicular size, testicular atrophy if present, because that could be leading then to a decreased amount of testosterone production, and it could lead us down that sort of endocrine route versus something else, okay? The CBC and the basic metabolic panel, really what we're getting here was just making sure that everything looks good, especially we're really checking glucose more than anything. Testosterone, prolactin, TSH, thyroid, let's not forget our thyroid can play a big part. So check that. And then if testosterone is abnormal, because what you're going to order initially is total testosterone, and then if it's abnormal, then we'll go down the FSH, LH, and free testosterone routes. And then if we're finding something there, then we're going to head down the hypothalamic gonadal axis and more into the endocrine realm than the urology realm. Okay. Now, I'm going to show you some of these tests, like I said, and then we're going to swing out of primary care and then swing back in when we talk about treatment-wise. But this is what I was talking about: nocturnal tumescence monitoring to see if the physiology does work. Okay, like I said, it's like a sleep study. I have mentioned this in the past when we talked about priority disease and pre-surgical planning. So alprostatal is a prostaglandin inhibitor, right, PDE5 inhibitor, in a different sort of version. And it is administered as an intracavernosal injection. In this case, what we're talking about is an office procedure to see if the patient can achieve an erection at all. All right. Also can be used when we talk about treatment as a self-administered form. There are direct tests that check the arteries and the cavernous bodies for their rigidity, for their competence, if you will, to hold blood and maintain a rigid erection. But again, way, way, way down the line. And so we get to, what do we do for primary care? Try normal medication. Okay. So everybody, like we've discussed in many, many classes before, this is the slide that will most likely do the most good and benefit long-term for the patient, but it's also the hardest thing to get them to do. All right. If it is a medication, if we're chasing it down and we're thinking it's a medication reaction, if we can get them off of one med and onto another one, that would lessen the effect, that side effect, then that's good. If we can't, then we just kind of have to work around it, right? If there's a medicine that we just can't stop, the risk benefit isn't there, then we're just going to have to, again, try to adjust our medication on top of it. So we're treating a side effect because it's too important to not have them on that medication. And this is what I talked about a little bit. Holistic healthcare, right? Don't forget, again, if the anxiety portion is playing a large role in this, then the medication will help, yes, but might also contribute to that anxiety. Like the goal of a PDE5 inhibitor specifically, especially if we don't have to, is not to have the patient need it all the time for the rest of their life, okay, if possible. So if there's a large anxiety or psychosomatic component happening here, and we can break through that with a patient, then ideally we can reduce the amount of medication or even eliminate medication potentially. So don't forget about referral to behavioral health if necessary, okay? And looking at this is just a little study that I found. After 4 weeks, patients had a better outcome, all right, on that self-directed scale for somebody between patients who had just been given a medicine to patients who had been given medicine and a referral to behavioral health. So the therapy does help the patients. Again, not a catch-all, not a universal outcome, I should say, but just again something to think about. All right. So PDE5 inhibitors, I'm sure you've talked about them in the past, right? Always a good first line. For DOD, you got to use Viagra. They have to fail Viagra before you can give them something else. But what the real difference is between our PDE5 inhibitors is their therapeutic window, their duration, okay? So if you look side by side, Viagra all the way down to Stendra, they're about the same, right? Changes in the scale, right? So in this one, higher is better, right? So after and before. If you look, they're all about the same, right around an 8% increase. So it means the patient's saying that they are getting better. And they're all about the same. So this slide just really shows you that they're fairly interchangeable in their efficacy, all right? In their efficacy. But what makes them different one to the next, again, is their duration and their onset, all right? Remember, let's not give them if they're on nitro or nitrates, okay? And again, the priapism is the most popular or most known side effect, although probably one of the least common side effects. It doesn't really happen very often with these medications. And then relative contraindications, again, just do a good patient history, good medication history, make sure you're not going to give them anything that's going to cause harm. Standard of care, right? So, what do I mean by onset and duration? Well, you know what I mean by that, but why does that have anything to do with these medications, or what they're intended for? Anybody? Like, why would it matter? If one acts faster, lasts longer, what's the difference? Huh? Yeah, you guys are all, exactly, you guys are all, spontaneity, right? Sexual intercourse, sex isn't, most people don't like to have it on a schedule or as a planned event. If you are with your partner, you just want to have sex when you're ready to have sex. So, exactly what everybody's been saying. And you say that, again, it's easy to smile about that and laugh, but the truth about it is if you take that bit away, it's a normalcy from your patient, it's a real quality of life impairment. That everybody likes this. And what does it lead to? It leads to patient noncompliance, and then they just dive further into that hole because they don't want to take the medicine. First, they don't want to admit that they have to take the medicine anyway, because then they don't want to have to take the medicine because it's fairly, imagine you're with somebody new, not like your regular partner. Like, oh, excuse me, I have to take this medicine, and then, we'll have to do something for an hour, and then maybe, you know what I mean? It's not without its consequences, right? So anyway, our standard of care, our first one, the original, the OG little blue pill, right? 30, 60 minutes onset, duration up to 12 hours. So a thin, a seemingly, you could take it beforehand, and then, but you've got this sort of time, this finish line in the back of your mind, right? Make sure, the big thing with these, all of them, most of them I should say, if they do take this, like say before dinner, again, you go out on a date, you go to dinner, then you go out, whatever. If you eat a high-fat meal, then this might not work. So you have to tell your patients that as well, right? Thinking of things you take for granted, things that people take for granted, you have to think about with these type of patients, right? You just sort of take for granted sex, right? But then if it's taken away, now you have a lot of different things to think about. It really does add to the anxiety. Levitra, very much similar to Viagra, honestly. So not a whole lot in difference there. And then you get to Cialis, which is still more expensive for some reason, but probably the one that patients like the most. And why? Because 30 to 60 minutes, still the same, but 36 hours, right? So you have it in your system and it lasts for a long time, right? So it just gives the patient the ability to have a little bit more of a normal life for a longer period of time. And don't forget this down here at the bottom, if you have your patient who has BPH and ED, which the older you get, the more likely that cross-section is to occur, then you can give this patient one medicine that treats both. But you're going to switch from an as needed to an everyday smaller dose, okay, for the BPH indication. Stendra, I have not seen used very much. It has a shorter onset of action, but a similar duration to Viagra. It doesn't really provide much of a difference, to be honest. So, really the one that is I think the one that has the best patient satisfaction profile is Cialis. But again, DOD, you have to fail Viagra first. Which means what? It means the patient has to come back and say, I don't like this, and then you can give me Cialis. Self-administered injections, okay? Tuberculin syringe, you guys gotten your PPD before? Small needle when it's going into your arm, maybe a little bit bigger depending on where else you're putting it. So again, not exactly the most comfortable thing for patients to have to do immediately before intercourse. However, it is stronger in efficacy, so if physiology works, it will generally achieve an erection regardless, okay? Self-administered shot. Other ones you might hear about and you can prescribe is called Trimix. Usually, if you go to Europe, you can find these as individuals, but in the US, the only thing you're going to find in isolation is alprastatal, the one we just had in the previous slide. Trimix contains a couple more, just a similar efficacy, sometimes a longer duration of action with that Trimix one. Okay. Same medicine, but in a urethral suppository. Okay. So again, an applicator, and then it's transmucosal absorption. Smaller than a grain of rice, but again, small is relative to where you have to put that grain of rice. Okay? So, patients generally like the shot better than this, to be honest with you. Hormonal replacement, if they do have a confirmed androgen deficiency, so we find somebody that we do have a low T, then we can send them for, or we can prescribe testosterone replacement, usually as an adjunct. Okay? I don't know if you've seen commercials lately, but there's a new over-the-counter called Erectile Gel. It basically is, you see what's in it? Ethanol, propylene glycoglycerin. So basically what it does is it dissolves quickly and creates a cold sensation that stimulates the nerves and helps to achieve an erection. It has decent efficacy. It's not something that we prescribe, it's just over-the-counter. But it works through evaporative cooling, so if your patient doesn't want to take a medicine, if they're not a good candidate for a medicine for whatever reason, they can try this. Some of them may have already tried it, so again, just make sure you're aware of all of these things that are coming out of the market and the ways your patients can get them, so you ask and make sure you don't double up on something. All right? Vacuum erection devices. This is real. This is a real durable medical item that you can prescribe. The reason we get to this point is, who do you think, what is the patient subset that you think we would use something like this for? Spinal cord injuries, neurologic impairment, right? You can imagine, they've already dealt with that, and now you can, at least in some form or fashion, add sex back to their life. It is not a small thing. Okay, so yes, it is fun. We've all seen Austin Powers, all right? But it is something that, or some of us have seen Austin Powers. Like, you haven't seen Austin Powers, huh? Get out of my class. It is something that it can be, because sometimes the physiology just doesn't work. So the medications will not achieve it. Okay? And so this allows that element of their life to be given back, and it's not a small thing. Okay? And again, enough about that. But this is a more common surgery than you might be aware. But essentially what this is, if you look, I'm just going to do it on here so you can both all see. This is a balloon reservoir. And you guys remember Reebok pumps? This is a little pump device that can be placed in the scrotum typically. All right? And the air leaves the reservoirs and inflates these two devices that are placed into the cavernous bodies. And so the patient just pumps up when they're ready to have sex, and then there's a release. You know, if you hold it down as a release, and it releases back into the reservoir, and the patient can have semi-normal erectile physiology. Okay? So it's more common than you might think. More common than these, but there are this. I mean, literally, these are bend it up, bend it back down rods. Okay? And there's a picture of them being put in. But the balloon thing is more common, at least in my experience. Vascular reconstruction, this is when you get, I mean, when we're talking surgery, now we're talking way down the line. This patient has failed everything, all right? And like I said, once you get past, you try one PDE5 inhibitor, it doesn't work. You give them, you know, you go from Viagra to Levitra or Cialis. They don't have the intended effect or sufficient reduction in symptoms. That's when it's time for primary care to send them on to urology for further evaluation, all right? And then again, these are like last resort. When you get down to vascular surgery, you're really not going to have much success. Most of the time, I don't know why they would proceed past this. This would generally, the balloon implantation device is going to be done in favor of something like this. Now, if you go or hear about, this is more stuff your patient might be experiencing or have tried on their own. Especially this one, okay? Low intensity extracorporeal shockwave, all right? You guys remember that shockwave therapy for kidney stones? So just blast the sound waves through it. In this case, it's a lower intensity intended to increase vascular neogenesis, to try to increase blood flow to the area and then create rigid erections and treat erectile dysfunction. It's still very, very limited, but what you will find is places like Synergenics and some of the low T centers and places like, and things like that, they're, the hormone replacement centers will offer this therapy to patients, but it's very problematic because this uses an actual ultrasonic probe. The thing that they will often use at those sort of spurious credentialed places are essentially massage guns, all right? And that can cause damage to the cavernous bodies. It can lead to fibrosis. It can lead to Peyronie disease. So depending on the credentials of the provider, depending on the machine they're actually using, they can actually get a lot worse. So just tell your patients, if they're going to these places, and they will, just to be careful and know exactly what they're getting from the provider, all right? Intracovenantal stem injections and PRP, still very experimental, investigational, so it's not something, these are not standard of care, so if your patients are going somewhere and being offered these things, you should tell them to not, all right? But again, low intensity shockwave therapy and actual ultrasonic probe versus radial wave, which is, like I said, essentially a massage gun. All right, can cause a lot of problems with your patients if they are undergoing that type of therapy. So they need to educate themselves, and you need to be educated so you can help educate them. Okay. And let's see. Again, because of the preponderance of vascular ED or vascular-related ED, just it's a good opportunity for you to talk about cardiovascular risk factors with your patient. Right? So don't miss the forest for the trees. A lot of times, if you can affect change on their cardiovascular risk factors, then that becomes a treatment for the ED itself. Okay? And another one, again, embarrassing for your patient to come talk to you about, but if they do, just keep your poker face, all right? So, premature ejaculation patient definitions. One is lifelong, the other is acquired. So did it just start? Usually it's more of a situational psychogenic thing, whereas if it's been like a lifelong problem, it's more of a organic type of thing, all right? There is a definition of what premature ejaculation is, so you know. There is another standardized tool for you to use. And again, you don't have to memorize the names of these, you just have to know that they exist. So that when these patients come to you, you can Google it and have them fill it out, all right? And again, the reason I circled paroxetine is because it generally has the highest efficacy. On this side, highest efficacy of helping with premature ejaculation. On the treatment for depression side, it has the highest incidence of sexual dysfunction. So depending on the patient you're treating, what you're using it for, just be aware of that, okay? All right, any questions? Sweet. Let's take a 10-minute break. We'll finish off with infertility. We should go by pretty quickly, and then maybe Dr. Klein will come in early. All right, infertility, and you guys are going to talk about female infertility in the women's health class, unless you already have. So we're going to focus mostly on the male partner side in this case. And honestly, what do you all think is the basis of a male infertility workup? Sperm, or testing thereof. Yes. So yeah, semen analysis, that's the word I'm looking for. But what was one thing we already talked about that can cause, it can be an insidious cause of infertility? Do you guys remember? Huh? Mumps? Okay, yes. Varicocele, yeah. What was the one you said? Cryptorganism, that. And then varicocele. Varicocele. That's the one I was going for too. So again, easy, sort of fixable. So, collect myself here. So 1 year, that's the definition. You already did talk about infertility in women's health. Okay, so a lot of this may be review, which is good. Right? These are the reasons why you would, and then cryptorganism is on there, why you might initiate a true workup / referral process earlier than 1 year. In general, the 1 year cutoff is when is the amount of workup and trying that the couples are going to have to go through before a infertility specialist will accept them. Right? That's the year cutoff. Okay? But again, if you have bilateral cryptorganism or if you have advanced maternal age, which you might say 35 isn't that advanced, but it would be able to warrant a early referral to infertility. Okay? The real problem with infertility, I'm not sure, hopefully Dr. Love said something similar, is that a lot of times the answer is just, we don't know. Like it's idiopathic. So a lot of the times you won't necessarily get to a granular answer of this is why it's happening so we can fix it. Infertility is notoriously difficult and difficult for couples to deal with. And that's the sort of takeaway here, is that in many cases it's just we get to I don't know, keep trying, good luck, there's not much else we can do, or move that couple onto advanced fertility techniques. Couple of terms you might see these on the semen analysis. Azoospermia, just a little hint for y'all, I don't think it's in the slides anymore, but if you have somebody who has azoospermia, meaning a complete absence of sperm cells, spermatogoa in the ejaculate, then they need to have a testicular biopsy. So that would be something you need to send somebody up sooner for, okay? Just spermatogenesis in general takes 3 months, so not that you wouldn't, but make sure you do a good, strong investigation of the past 3 months at least. Meaning what? Have you started any new medications? Are you taking any over-the-counter supplements? Anything like any changes in activity, diet, exercise, that kind of stuff. Just make sure you understand that that's the critical portion. All right. And then we covered female stuff and women's health, but these are important. Family history of reproductivity, or especially reproductive history of the partners. Have you ever been able to achieve a pregnancy successfully in the past? Okay? Meaning, has the male patient had any successful pregnancies himself, or has the female ever been able to achieve pregnancy herself, right, with other partners? There's another mnemonic for you for things that would be our common culprits, our most common culprits for infertility factors for male patients. All right, and pretty simple. Medications. You don't need to memorize the individual medications that are on this list. Just understand that there's a number of them. So when you're actually sitting across from a patient who is complaining or having difficulties with achieving pregnancy, you really have to do a deep dive into every medication, every supplement, every vitamin that they're taking, and see if it could be the culprit. Because sometimes doing something as eliminating, Zantac out of their regimen is something that's going to affect change, okay? Big ones on here: marijuana, cigarette, okay? And then varicocele, prolonged heat exposure. Again, just the physiologic reason for the scrotum to exist is to keep the testes away from the body for spermatogenesis. If you've got all these big dilated tortuous veins with all the hot body temperature blood coursing through them, it's going to affect spermatogenesis. And then, you mentioned orchitis. Potentially epididymitis. I mean, if we have a frequent history of epididymitis, like a frequent STI history, that would be more likely, potentially, because of inflammation or fibrosis and the spermatic seminiferous ductules, right? Prostatitis, not so much, but cryptorganism is the big one on here. Hydrocele and hernia can potentially lead to similar outcomes as varicocele, although not as common, right? Unless you have a really big hernia. History of torsion, depending on the length of time before it was corrected, just because of the ischemia to the tissue, could cause prolonged tissue damage. You're gonna have to, I tell students that you guys are gonna have weird conversations with people, things that you never thought you'd have to tell a human being that's theoretically functioning in a room with oxygen in it. Like, don't wear condoms if you're trying to get pregnant, which is something I've had to tell people before. All right. Spermicidal lubricants kill sperm, so stop using those. Okay. Just things like that, you'd be surprised. So you have to ask questions. Just understand, things that you take for granted as obvious are not obvious to everybody. Okay. Everybody in this room is really smart. Not everybody in this world is really smart. Okay? So just understand that you're going to have to ask some things that you might just think are so stupidly obvious that no actual reasonable person would do them. That's the thing that you might need to uncover that they're doing. All right? Prior fertility, obviously, how long has this been going on? How long have you been trying? How long have you been actively trying to get pregnant? And then have you ever achieved, or has your partner ever achieved a pregnancy before? Really important questions to elicit. A physical exam in general, unless you find obvious secondary sex characteristics, if you find cryptorganism, it's going to generally be a normal physical exam, all right? But just make sure you do a good thorough physical exam, checking for gynecomastia, checking, a good genital exam, all right? And then do a digital rectal prostate exam as warranted, all right? I don't know if Dr. Klein has mentioned these Mardi Gras beads here, but they are orchiometers, all right? So you can, it's an appropriate, are you going to have those? No, but they exist, so you know. But you want to make sure that, again, you're looking for any kind of testicular atrophy or any kind of testicular, just genetically small testicles, right? That might indicate a lack of secondary sex characteristics, might indicate a lack of testosterone production, okay? Again, check for varicocele. Have the patient Valsalva, even if it's not clinically obvious, so it might engorge and allow you to feel it. And still, what do you think is going to be, besides this semen analysis, what do you think is another thing we're going to get for these patients? Ultrasound, right? Ultrasound, right? Okay? And really what this whole presentation boils down to, if it seems like I'm going really fast, it's making sure that you've done 12 months of diligence of trying. You've given them the proper patient education about not using anything that's going to affect their fertility, like spermicidal lubricants, et cetera, making sure their meds are good, and then really boiling it down to getting a semen analysis and a couple extra labs. All right, that's not a whole lot we can do other than just make sure we're really checking off obvious causes of why this might be occurring. All right, so 2 days of ejaculatory abstinence, which means no sex and no masturbation. We need a good sample, or else we're going to get a falsely low number, potentially, right? So we really want to get a good sample. The reason I highlight 30 minutes is because you can send patients home to do this, but they need to be able to get that sample back to the lab within 30 minutes, or the spermatozoa are going to start to die, and then again, we're going to have falsely abnormal results. Okay? The reason I tell you that is because at BAMC, at some labs, some hospitals, they have a lab that has a separate area with a bathroom for this purpose. At BAMC, they just give you a cup and tell you good luck. Right? So Just so you know, I'm not joking. They don't have a specialized bathroom, a specialized area for this where you can go have lock, where you're not gonna be trying to produce a sample and we're just gonna throw it off, right? So, I'm being silly. I am serious about BAMC, but I'm being silly. But truthfully, you have to impress upon your patient that if you decide to go home and do this, you have to make sure you get it back. And the reason is, think about a place like San Antonio, right? If your patient lives about 20 minutes away, is anything ever the normal amount of time to get to anywhere, right? So then that whole sample is wasted. Then you have to wait 2 more days where you can order a new one, and so on and so forth. It just prolongs everything, and it gives you the real potential of getting a false abnormal sample, all right? Anyway, the parameters, you don't have to memorize these. These are just the parameters. You're going to get all this on your results, and if anything is abnormal, then you can look into why it is abnormal. But what they're going to look for is, are the sperm cells shaped correctly, right? Morphology. Are they all swimming? Are they swimming in the same direction, right? Because that is what they're designed to do, all right? The concentration of the overall sample, the amount of fluid volume, because it could be a problem of glucose or fluid, where the spermatozoa don't have literally enough food to get to their destination, all right? So semen fructose is another thing that you can order. But you remember we were talking about rubber match, right? 2 alike samples. We talked about that with hemature. We talked about that with proteinuria, right? Remember? It's the same thing here, right? So if you get one sample and it's abnormal, then get another one to make sure that it is really an abnormal sample before you take that. If one is normal, make sure you get a second normal one. If you get 2 different ones, then get a 3rd one. You guys know what I'm talking about, right? We talked about this with everything on, right? You're just confirming the results of the test, right? Is the first one falsely normal? Second one, it's also normal? We're good. First one's abnormal, second one's abnormal, we're good. We don't have to go into the 3rd. Now you might say, what if the parameters are different? Like if you have an abnormal parameter, and then in the second one, that some of the parameters are differently abnormal. Don't worry about that. That's good enough. If you have abnormal and you get another abnormal, take it from there. Does that make sense? All right, we're not going to get 18 different semen analysis. This one right here, it just establishes the lower end of normal. Different institutions will vary. All right, this is the WHO. It's basically the 95, the 95th percentile, or I should say the 5th percentile. All right, so the 5th percentile establishes what the low end of normal is for semen samples. And the 2 takeaways on this slide are not to memorize anything. It's one, infertility. You can't, if a patient has an abnormal semen analysis, you can't say, well, you are infertile because of this. It's in multiple different factors, right? It is a factor, but it's not the only one. And then what this graph sort of illustrates is that there's sort of an exponential growth with the increased number of abnormal parameters on the patient sample. The more individual parameters that are abnormal, the likelihood of infertility rises dramatically, okay? Other labs, don't forget the hypothalamic pituitary gonadal axis, right? So we're going to check all those hormones. And then, again, as warranted here. So these, essentially, in addition to your semen analysis, you should get these, establish a baseline, okay? Baseline labs. And this is for all the endo nerds out there. All right. Am I going too fast? Am I losing you guys? I am? Huh? Yeah. You can't just say I mean, I'm not going to change anything. I just like to, periodically poll the audience. Right? Scrotal ultrasound. I know it says as indicated. You might as well just scratch that off. Just get the scrotal ultrasound again. We want to make sure if there's a subclinical varicocele, that can be an easily fixable item, right? Transrectal ultrasound, not necessarily. This would probably go with, this we're going to 100%. The rest of these, we'd say as indicated, right? Depending on if any of our labs suggest. Right, if we're really going down the endo route, maybe a maybe a pituitary MRI might be warranted. Transrectal ultrasound, if we're thinking that we're going to find something. Usually the prostate is not a huge culprit in this, but a scrotal ultrasound definitely, because we want to see, one, is there varicocele 2 testicular size and morphology, right? This will elicit it for us specifically so they understand maybe the patient has abnormally small testicles, abnormally large testicles. That would indicate something else that might be an issue. Okay? So, bottom line, patient education, right? Patient education, right? And our referrals as necessary. So what are we going to do? What is the primary care role? I already said. Patient comes to you, have you been trying for 12 months? Does that mean we can't start doing labs until after 12 months? No, all right, no. But we're not going to make any referrals until after 12 months, okay? So we come, labs, endocrine labs, basic labs, CBC, CMP, sperm, and then semen analysis. Semen analysis, what are we going to do? Get 2 samples that give us a confirmatory result, right? So 1, 2 that match. And then refer on as necessary. Okay. This is just something that you might read about, oxidative stress, infertility, so thinking that free radicals have a role to play in spermatogenesis, and so you may find patients that come to you taking an antioxidant. Most of them are pretty innocuous, so there's really no reason to take them off, or you may even consider recommending one of these to your patients, okay, just to help, all right, just to help. And the big one here again is a lot of times, when patients come to us, it's because they're looking for an answer. They're looking for us to be able to do something to fix the problem. And these infertility workups are fairly notorious for resulting in, we don't have a good answer for you, we're sorry. And that's difficult for patients to deal with. So, if you start to get to that area, obviously the infertility specialist will do this, but then you start to talk about the possibility of advanced reproductive techniques and other means like adoption and so on and so forth, okay? I know that was really quick, but you guys got it. It's pretty kind of a bottom line up front. Slide deck. That's all I got for today. We'll finish up tomorrow, okay? Any questions?